Usually when we picture human architecture, we tend to think of something completely static, like a skyscraper or a suspension bridge.
Right. Something with foundations completely fixed in concrete. Immovable.
Exactly. But when you actually look at the human lower limb, you're looking at a living, dynamic, weight-bearing column. It has to absorb the massive shock of running, pivot on a dime to change direction, and simultaneously carry the entire mass of the trunk.
It's an absolute mechanical marvel. It really is.
It is. But from a surgical perspective, that intense biomechanical complexity means, well, there are just countless ways it can fundamentally fail.
Oh, absolutely. It's the ultimate biomechanical balancing act. And understanding exactly how this dynamic structure is, wired, plumbed, and bolted together, it isn't just academic. It's a completely non-negotiable when you're in the operating theater.
You have to know what's under the hood before you make a single incision.
Ex-
So welcome to this rapid-fire revision deep dive. If you're a resident preparing for your MRCS exams, you are in exactly the right place. We're focusing entirely on high-yield lower limb anatomy and the clinical applications you absolutely must know.
We're breaking down the question and explanation logic you really need to survive the exam.
Yeah, and before we get going, just take a second to press follow right now so you catch all future revision deep dives. And, please rate the show if you find this session helpful for your exam prep.
And honestly, the more you drill the why and how behind these anatomical relationships, rather than just memorizing lists, the more second nature they become when you actually have a patient in front of you.
Speaking of having a patient in front of you, as you review this anatomical theory, you really need to be keeping your hands moving. So head directly to megzinklimited.com right now to get your surgical simulation kit.
Highly recommend that.
Yeah, it includes a suturing kit, microsurgery instruments, and more. It is essential for getting that hands-on practice while we drill the theory. So go to megzinklimited.com and secure yours. Okay, let's unpack this. We have to start at the absolute foundation of this weight-bearing system.
The pelvic girdle.
Right. We're looking at the massive bony structures that distribute the trunk's weight and those very specific gateways where vital vessels and nerves escape into the leg. So walk me through the innominate bone and the acetabulum. Why are the fusion ratios so specific here?
Well, the hip bone, or innominate bone, is fascinating because it's actually formed by the fusion of 3 separate bones, and they meet right at the center of the acetabulum, which is the socket for the femoral head.
Right, the ilium, ischium, and pubis.
Exactly. And for the exam, you need to know the exact ratios of this fusion because it basically dictates how weight is transferred. So the acetabulum consists of about 1/5 pubis anteriorly, 2/5 ilium superiorly, and 2/5 ischium posteriorly.
So mechanically, that makes perfect sense. The ilium gives us that broad, thin blade anterosuperiorly for massive muscle attachments, but its postero-inferior part is a really thick bar of bone, right? Specifically for transmitting the weight of the spine straight down to the femur.
That's right. And then the pubis forms the anterior part, shaped kind of like a rotated L.
And the ischium is that heavy J-shaped bone posteriorly, where we find the ischial tuberosity, which is, the part we actually sit on.
Exactly. That's your sitting bone. And the key to understanding the pelvic exits lies right on the posterior border of that ischial body. There's this single bony projection called the ischial spine.
Okay.
It's incredibly critical because it acts as a dividing line. It separates the greater sciatic notch above it from the lesser sciatic notch right below it.
Which brings up something I always think about. I like to picture the greater and lesser sciatic foramina as like high-security border crossings. You have these massive ligamentous walls dictating exactly what is allowed to leave the pelvis and what has to stay inside.
That's a great analogy.
So how do we get from a simple bony notch to a secure foramen? And what exactly gets through the border?
Well, it's all about the ligaments transforming the architecture,
Yeah.
You have the sacrotuberous ligament, which passes from the ischial tuberosity to the side of the sacrum and coccyx.
Right.
And then you have the sacrospinous ligament. That one passes from that ischial spine we just mentioned, also attaching to the side of the sacrum and coccyx. So by bridging those gaps, these 2 ligaments physically convert the open sciatic notches into closed tunnels.
The greater and lesser sciatic forama.
Precisely.
Okay, let's drill down into the greater sciatic foramen because that's really the main highway out. And the absolute key to this crossing is the piriformis muscle, right? It's basically the traffic cop of the pelvis.
Oh, that's a perfect way to look at it. The piriformis originates on the anterior surface of the sacrum inside the pelvis, and it passes straight out of the greater sciatic foramen to reach the femur.
And it takes up a lot of room.
It does. Because it physically occupies so much of that space, we categorize everything passing through this foramen strictly by its relationship to the piriformis. So above the piriformis muscle, you have the superior gluteal vessels and the superior gluteal nerve.
Okay, wait, so if the superior gluteal bundle is above it, what's below it? Because whenever I look at textbook diagrams, the space below the piriformis looks like absolute gridlock.
Oh, it is absolute gridlock, and it's highly testable for the MRCS. Below the piriformis, you have the inferior gluteal vessels and nerve, the internal pudendal vessels and nerve, the massive sciatic nerve.
Wow, that's a lot.
Yeah, and we're not done. You also have the posterior cutaneous nerve of the thigh, the nerve to quadratus femoris, and the nerve to obturator internus.
Okay, let's focus on that sciatic nerve for a second, because clinically speaking, if we have a patient requiring an intramuscular injection in the gluteal region, that massive nerve coming out right below the piriformis is like our primary hazard.
Absolutely. It's a huge risk.
So what is the precise surface marking a surgeon or a nurse needs to know to avoid just paralyzing the patient's limb?
Well, the surface marking of the sciatic nerve is essentially represented by a curved line. You find it by joining two midpoints. First, the midpoint between the posterior superior iliac spine and the ischial tuberosity.
Okay.
And second, the midpoint between the ischial tuberosity and the greater trochanter. To completely avoid this curved danger zone, you must inject into the upper and outer quadrant of the buttock.
I really want to emphasize this for everyone listening because the terminology constantly trips people up. The anatomical buttock extends all the way up to the iliac crest and laterally to the greater trochanter.
Right, it's a large area.
It does not just mean the aesthetically pleasing mound of flesh at the bottom. If you aim low into the fleshy part, you're going to hit that sciatic nerve or the inferior gluteal vessels. You just have to aim high and lateral.
It's a vital clinical pearl. I mean, anatomy doesn't care about aesthetics. It cares about bony landmarks. And once those massive vessels and nerves clear the safety of the pelvis, they have to navigate the tight confines of the thigh.
Right, which brings us to the high-yield transit zones. We have these anatomical bottlenecks, the femoral triangle in the front and the popliteal fossa in the back, behind the knee.
Both classic exam topics.
So let's start anteriorly. I always picture the femoral sheath sitting inside that triangle like a three-lane highway. Can you map out the borders of the overall triangle first, and then tell me exactly what's driving in which lane of that highway?
Sure, let's build the boundaries first. The femoral triangle is bounded superiorly by the inguinal ligament, medially by the medial border of the adductor longus muscle, and laterally by the medial border of the sartorius muscle.
And what about the floor?
The floor is a muscular bed. It's made up of the iliacus, the psoas major tendon, the pectineus, and the adductor longus.
Okay, and the deep fascia of the thigh forms the roof over it. So how does the femoral sheath fit into that space?
Well, the femoral sheath is actually a funnel-like prolongation of the fascia from the abdomen. Specifically, the transversalis fascia anteriorly and the fascia over the iliacus posteriorly.
Okay, I'm visualizing that.
Yeah, so going back to your three-lane highway analogy, this fascial tube is divided into three distinct compartments by septa. The lateral compartment, the fast lane, if you will, contains the highly pressurized femoral artery.
Got it.
The middle compartment contains the femoral vein, and the medial compartment is the femoral canal.
Now, I have to ask about that medial lane, the femoral canal. Why is it mostly empty? I know it contains fat in a deep inguinal lymph node, Cocai's node, but mechanically, why is there a whole empty lane in the sheath?
That's a great question. It's essentially the shoulder of your highway, right?
Wow.
And it's there for a crucial physiological reason. The femoral vein needs room to expand.
Oh, of course.
Yeah, when you're running or exercising heavily, venous return from the leg drastically increases. That empty medial canal gives the thin-walled vein the physical space it actually needs to dilate without, compressing the femoral artery next to it.
That is brilliant. Form completely follows function. And crucially for the exam, the femoral nerve is strictly outside the femoral sheath, right?
Correct.
It's not on the highway at all. It's lying laterally on the iliopsoas muscle.
Exactly. Do not put the femoral nerve in the sheath on your exam.
Good tip. Now, moving down the limb, that femoral artery passes through the adductor canal, slips through a literal hole, the hiatus in the adductor magnus, and suddenly pops out behind the knee to become the popliteal artery. This puts it squarely in the popliteal fossa. What exactly is boxing it in back there?
The popliteal fossa is this diamond-shaped space right behind the knee. Above and medial, you have the semimembranosus and semitendinosus muscles. Above and lateral is the biceps femoris tendon. Below and lateral is the lateral head of the gastrocnemius, and below and medial is the medial head of the gastrocnemius. But the critical point for the MRCS here is the depth of the structures.
The arrangement from deep to superficial.
Yes. The popliteal artery is the absolute deepest structure in this entire fossa. It lies directly against the popliteal surface of the femur and the capsule of the knee joint. Superficial to the artery is the popliteal vein, and most superficial of all is the tibial nerve.
Okay, so what does this all mean for a trauma patient? Let's say a patient comes into the emergency department with a supracondylar fracture of the femur, a break just above the knee. A broken femur isn't just an orthopedic bone issue, is it? It's an immediate vascular crisis, because the patient's own calf muscles are essentially pulling the bone right into the blood supply.
That is exactly the causal mechanism you need to visualize. Think about the attachments. The massive gastrocnemius muscle attaches just above the femoral condyles.
Okay, right.
When the femur breaks right above that attachment, the gastrocnemius violently pulls and tilts the distal bone fragment posteriorly.
Backwards into the fossa.
Exactly. Because the popliteal artery is resting directly against that bone, the sharp, fractured proximal edge of that distal fragment is pulled straight backwards like a blade right into the artery. It can easily impinge upon it, tear the intima, or completely sever the artery.
Wow, it's a terrifying mechanical trap. You're basically fighting the patient's own muscle spasms to save the limb's blood supply.
It's an absolute emergency.
And because that popliteal artery lies right against the back of the knee capsule, it makes you wonder how the knee itself doesn't just crush it during normal movement. I mean, the knee joint is structurally absurd.
It really is.
You have the flat, plateau-like articular surfaces of the tibia and the round, heavy condyles of the femur just like sitting on top of them. It's essentially two boulders resting on a flat plate. So how does the internal ligamentous bracing actually keep us standing without collapsing?
You're totally right. Bony-wise, it's highly unstable. It relies almost entirely on soft tissue engineering, specifically the cruciate ligaments inside the joint, the menisci, and the surrounding musculature.
Walk us through the cruciates.
Sure. So the cruciate ligaments cross each other like an X. The anterior cruciate ligament, the ACL, runs from the front of the intercondylar area of the tibia obliquely upwards and backwards to the lateral condyle of the femur.
And its job.
Its entire job is to prevent the tibia from sliding forwards out from under the femur. Meanwhile, the posterior cruciate ligament, the PCL, goes from the posterior tibia upwards and forwards to the medial condyle, preventing a backwards displacement.
Okay, but what about the locking mechanism? I always struggle with this part. If the knee is basically a wobbly hinge held together by rubber bands, how do we stand upright for hours without our thigh muscles just giving out from exhaustion? There has to be a mechanical lock.
There is, and it's brilliantly designed. It's called the screw-home mechanism.
Right.
When you approach full extension straightening your leg, the medial condyle of the femur is actually slightly longer than the lateral one. So as the joint fully extends, the tibia is forced to slightly rotate laterally relative to the femur.
And that tiny rotation does what?
It twists all the major ligaments taut, wringing them tight like a wet towel. The joint physically locks into a rigid, stable column that requires almost no muscle energy to maintain.
That's incredible. And to bend the knee again, you have to unlock it, right? So the popliteus muscle fires medially rotates the tibia to untwist those ligaments and frees the joint so the hamstrings can pull it into flexion.
Pure mechanics.
Now, from the knee down, the deep fascia of the lower leg is incredibly tight, dividing the muscles into three distinct compartments, the anterior, the posterior, and the lateral. Let's walk through the neurovascular wiring for each, because they are huge exam topics.
Okay, let's start up front. The anterior compartment contains your dorsiflexors, the muscles that pull your foot up. You've got the tibialis anterior, extensor hallucis longus, and extensor digitorum longus.
And the wiring.
The nerve driving this compartment is the deep peroneal nerve, and the blood supply is the anterior tibial artery.
Got it. Moving around to the back, we have the massive posterior compartment, the calves and deep plantar flexors.
Right. The posterior compartment contains the gastrocnemius, soleus, plantaris, popliteus, and the deep flexors of the coes.
That's a lot of muscle mass.
It is. And because this compartment generates the massive push-off force for walking, it needs serious wiring. They are all supplied by the thick tibial nerve, and the blood supply is the posterior tibial artery.
Makes sense. And finally, the lateral compartment on the outside of the leg.
This one is simpler. It basically contains the peroneus longus and peroneus brevis muscles, which everett the foot. The nerve here is the superficial peroneal nerve, and the artery is the peroneal artery, which is actually a branch that dives off the posterior tibial artery.
Let's apply this wiring to a classic exam scenario.
Yeah.
Foot drop. We usually see this from an injury to the common peroneal nerve as it awkwardly winds, like completely exposed around the neck of the fibula.
Very common injury point.
Yeah, you see this with car bumper injuries striking the outside of the leg, or even from a badly applied, tight, below-knee cast compressing the nerve against the bone. I really want to clarify the exact clinical presentation here. If the common peroneal nerve is crushed up high at the fibular neck before it splits into its branches, the patient loses both the deep and superficial peroneal functions, right?
Precisely. You have to trace the wiring downstream. If the main trunk is out, everything below it dies. They lose dorsiflexion because the deep branch to the anterior compartment is dead, so the foot hangs down.
The drop itself.
Exactly. And they lose aversion because the superficial branch to the lateral compartment is dead, so the foot points inwards. To walk without physically dragging their toes on the floor, the patient has to consciously adopt a high-stepping gait, exaggerating their hip and knee flexion just to clear the ground.
Which perfectly illustrates why we need to trace this entire wiring system back to its source. It's like tracing the electrical grid of a house back to the main breaker panel.
Good analogy.
The nerves in the leg dictate the function, but for the MRCS, you must know their origins in the lumbar and sacral plexuses. So what are the absolute must-know root values here, and why are they grouped the way they are?
Well, let's tackle the lumbar plexus first. It's formed from the anterior primary rami of L1 to L4. The two major terminal branches you absolutely must know are the femoral nerve and the obturator nerve.
And they share roots, right?
They do. What's crucial here is that both share the exact same root values, L2, L3, and L4.
So why do they go to different places?
The separation happens due to the pelvic architecture. The femoral nerve emerges from the lateral border of the psoas major muscle to head down the front of the thigh, while the obturator nerve uniquely emerges from the medial border of the psoas and dives deep down through the obturator foramen in the pelvis.
And the sacral plexus handles the back of the leg.
Exactly. The sacral plexus is formed from L4 all the way down to S4. The most significant output is the sciatic nerve, which is literally the largest nerve in the human body. It's as thick as your thumb.
It's massive.
And its root value pulls from both the lower lumbar and upper sacral segments, L4, L5, S1, S2, and S3. It exits the greater sciatic foramen, descends the back of the thigh, and eventually splits into the tibial and common peroneal nerves we just discussed.
So, simply put, the femoral nerve supplies the front of the thigh, the obturator supplies the medial thigh, and the sciatic supplies the back of the thigh and literally everything below the knee.
That's the summary you need.
Perfect. So let's talk about how this shared wiring creates clinical illusions, specifically Hilton's law.
Hilton's law is a beautiful anatomical principle. It states that the nerve supplying a joint also supplies the muscles moving that joint and the skin overlying the insertions of those muscles.
Okay, so how does that apply here?
Well, developmentally, the hip joint and the knee joint share the same fundamental nerve supplies. They both receive branches from the femoral, obturator, and sciatic nerves. Because the brain receives signals from the same anatomical wires, severe pathology in the hip frequently refers pain straight down to the knee.
That is such a crucial diagnostic trap. A patient comes in complaining of severe knee pain, but you examine the knee and the joint is totally fine. You have to check the hip because the brain is essentially misinterpreting where the fire alarm is coming from.
Exactly.
Another high-yield clinical correlation involves the obturator nerve specifically. We mentioned it dives through the obturator foramen in the pelvis. What happens if a piece of bowel pushes into that canal and an obturator hernia develops?
Well, the space is rigidly confined by bone and tough membrane. So an obstructed or strangulated obturator hernia will rapidly expand and physically crush the obturator nerve against the bone.
Ouch.
Yeah. Now remember what the obturator nerve does. It supplies the adductor muscles, but it also provides cutaneous sensation to the medial aspect of the thigh.
So to underscore this for you listening, if you get an MRCS question presenting an elderly patient with vomiting and signs of intestinal obstruction, and they're inexplicably complaining of severe isolated pain radiating down the inside of their thigh to the knee, that is the classic high-yield indicator of an obturator hernia.
Do not miss that.
The bowel obstruction and the leg pain are the same problem.
Absolutely. The thigh pain is a direct mechanical consequence of the hernia compressing the nerve. You fix the hernia, you cure the leg pain.
It's brilliant. Now, all of this anatomy we've covered, the heavy pelvic bones, the massive femur, the neurovascular transit zones, the plexuses, it all ultimately serves one singular purpose: transferring the entire weight of the human body safely into the ground via the ankle and foot.
The final destination.
Right. How is the ankle joint specifically constructed to handle this extreme dynamic force without instantly snapping?
It survives because it's constructed exactly like a mortise and tenon joint, which is a technique carpenters have used for thousands of years for maximum structural integrity.
That makes sense.
Yeah, the lower ends of the tibia and the fibula form a deep rectangular socket, that's the mortise. The body of the talus bone in the foot is the tenon that wedges perfectly up into it. But here is the absolute genius of the design. The superior articular surface of the talus is actually wider in the front than it is in the back.
Wait, so it's shaped like a wedge?
Exactly, a wedge. So when you dorsiflex your foot, like when you're walking uphill or pushing off, the widest anterior part of the talus is forcefully driven back into the narrowest part of the bony mortise.
Oh, wow.
Yeah, it spreads the tibia and fibula slightly apart, making the joint incredibly tight and stable exactly when you need it most.
But the bony wedge alone isn't enough to stop the ankle from rolling right. We rely heavily on the medial and lateral ligamentous support. Let's contrast them because their anatomy dictates their injury patterns.
Definitely. The medial side of the ankle is reinforced by the deltoid ligament. It is a massive, incredibly robust, triangular sheet of tissue running from the medial malleolus down to the talus, navicular, and calcaneum.
It's just one huge piece.
Basically. It's so strong that severe trauma will often rip the bone off before the ligament itself actually tears.
Wow. And the lateral side?
The lateral side, however, is structurally much weaker. Instead of one continuous sheet, it consists of three distinct separate bands: the anterior talofibular, the calcaneofibular, and the posterior talofibular ligaments.
This sets up a major rule for the exam and for, well, anyone working in the emergency department. The ankle stability is completely reliant on that tight mortise. A simple, violent tilt in the wrong direction completely overwhelms the soft tissue.
Exactly. Forced inversion or eversion violently tears those collateral ligaments. And because the lateral ligaments are just three smaller, distinct cords compared to the massive, unified medial deltoid ligament, lateral ligament injuries from forced inversion rolling your ankle inwards are by far the most common type of severe sprain.
And once that weight successfully transfers safely through the talus without tearing a ligament, it hits the arches of the foot. I always think of the arches as like muscular and ligamentous suspension bridges.
Very accurate.
Walk us through the medial longitudinal arch. What are the key struts holding this bridge up against the weight of gravity?
The medial longitudinal arch is structurally the most important for shock absorption. It's composed of the calcaneum at the heel, the talus, the navicular, the three cuneiforms, and the first three metatarsals.
That's a long bridge.
It is, and a bridge of bones will collapse without a keystone support. Here, that support is the spring ligament. It passes from the sustentaculum tali of the calcaneum directly across to the tuberosity of the navicular bone.
That's like a hammock.
Yeah, exactly. It acts as a massive fibrous sling directly underneath the heavy head of the talus, preventing it from dropping down towards the floor.
But if we're standing or running for hours, static ligaments will eventually stretch and fail. We have dynamic, active muscular support constantly tightening the bridge as well, right?
Definitely. The arch is actively and dynamically maintained by the strong tendons of the tibialis posterior, the flexor hallucis longus, and the flexor digitorum longus. They pull like thick steel cables under the bones, constantly firing and adjusting tension based on the terrain you're walking on and the weight placed upon them.
It's remarkable engineering. We have basically traced the weight, the blood supply, and the neural wiring all the way from the sacroiliac joint down to the tips of the metatarsals.
We covered a lot of ground.
We did. Let's briefly summarize what we've tackled in this deep dive. We broke down the mechanics of the pelvic exits and why the piriformis dictates the traffic. We mapped the three-lane highway of the femoral sheath and the danger of the popliteal fossa. We reviewed the knee's biomechanical locking mechanism, the leg's muscular compartments, and exactly how the lumbar and sacral plexuses wire them up.
Yep.
And finally, we detailed the wedge-shaped ankle mortise and the dynamic arches of the foot. Mastering these strict anatomical mechanisms and their direct clinical correlates is the key to conquering the MRCS. You cannot guess your way through this anatomy. You have to understand the why.
And understanding it doesn't just get you a passing score on an exam. I mean, it dictates how safely you open the lateral approach to the hip, or how confidently you explore the popliteal fossa after a massive trauma without cutting the very structures you're trying to save. Knowledge is only truly valuable when it's understood mechanistically and applied clinically.
Exactly. And speaking of applying that knowledge physically, I want to directly remind you to head to medsynclimited.com right now. Secure your surgical simulation kit, get the Suturing kit, get the microsurgery instruments, and get your hands moving and practicing while your brain is processing these deep dives. It's about muscle memory as much as mental memory.
Absolutely crucial.
Also, we really want to hear from you. Leave a comment or a question about today's content. Was there a specific anatomical boundary or mechanism, like the knee locking or the femoral canal, that finally clicked for you? Let us know. And please don't forget to press follow and rate the show if this session boosted your revision.
Every single piece of feedback helps us tailor these deep dives to exactly the high-yield material you need to succeed.
To end today's revision session, I want to leave you with a fascinating evolutionary paradox to ponder. We just spent all this time talking about how the talus bone is the absolute center point for transferring the entire weight of the human body into the foot.
Right.
It's perfectly wedged in that ankle mortise. But here's the paradox. The talus bone has absolutely no muscular attachments. None. Not a single muscle pulls directly on it. It is a purely mechanical, passive keystone wedged between the leg and the foot, relying entirely on surrounding ligaments, bone shape, and the tension of the arches to distribute the body's entire weight. As surgeons, it really makes you step back and ask, how much of our complex, high-tech, orthopedic intervention is ultimately just trying to surgically tape together an incredibly precarious, millions of years old architectural balancing act?